You walk into a clinic expecting a $40 copay. A few weeks later, you owe $1,184. Same doctor, same building, same exam room, same visit length. The only thing that changed? The building got bought by a hospital. And suddenly, you're not just paying for the doctor, you're paying for the room. The system calls it a facility fee. I call it the moment a normal doctor visit quietly turns into a hospital bill. You didn't get surgery. You didn't stay overnight. You didn't use an operating room. You didn't have a team of doctors sprinting down a hallway yelling medical acronyms. You sat in a room with a blood pressure cuff, a fake plant, and one of those paper-covered exam tables that somehow makes every human being feel like a sandwich. The doctor walked in, talked to you for maybe 12 minutes, looked at a screen, asked if you were still taking the same medications you already typed into the portal, and then you left thinking, okay, annoying but done. Then the bill shows up. And it's not one bill, it's two. One bill is for the doctor, the second bill is from the hospital system, for the facility. And you're sitting there thinking, what facility? I was in a regular office. But somehow that second charge is $250, $500, $900, sometimes more. Here's the part that should make you mad. The exact same doctor in the exact same building doing the exact same appointment can cost you hundreds more simply because the office is owned by a hospital. That is not a conspiracy theory. That is how medical billing often works. And here's the crazy part. In 2022, the average adult primary care visit in a regular physician office was about $116. But when a similar visit happened in a hospital outpatient setting, the average price was about $217. Same kind of care, almost twice the price. So the question is not, why is the emergency room expensive? We already know the emergency room is expensive. The real question is, how did a normal doctor visit become a hospital bill? My name is Nick, and I spend way too much time thinking about medical bills, health insurance, and all the weird little pricing games that make people feel like they need a law degree just to see a doctor. If you're someone who has ever opened a medical bill and thought, there is absolutely no way this is a real number, make sure to hit that subscribe button and give this video a thumbs up if this helps you out. Because today we're talking about hospital facility fees, what they are, why they exist, how they turn normal appointments into much bigger bills, and most importantly, what you can actually do before and after the bill arrives. Here's what most people don't realize. A facility fee is not always charged because you went to the hospital. Sometimes it's charged because the hospital bought the doctor's office you were already going to. Same parking lot, same waiting room, same doctor, same awkward paper gown, different billing category. And that billing category can change your entire financial experience. Quick question. If nothing about your visit looked more expensive, why did the bill triple? That's the whole game. Before I define this, I want you to remember one sentence. A facility fee is the charge that can make a normal appointment stop feeling normal. In plain English, a facility fee is a charge from a hospital or health system for the use of the facility, staff, equipment, and administrative infrastructure associated with your care. In theory, that can make sense. If you go to the emergency room, there is usually a facility fee. That emergency room has to be staffed 24/7. It has to be ready for strokes, heart attacks, trauma, infections, broken bones, and everything else people bring in at 2 o'clock in the morning. If you have surgery at a hospital, there are facility charges. You're using an operating room, anesthesia support, recovery space, equipment, nurses, sterile supplies, and a whole machine of people and systems. That part is not surprising. But this is where it gets really interesting. Facility fees are increasingly showing up in places that do not feel like hospitals at all. You might go to a regular outpatient office. It might be in a suburban medical building. It might look exactly like any other doctor's office you've ever visited. But if that office is owned by a hospital system and classified as a hospital outpatient department, your visit may be billed with both a professional fee and a facility fee. Professional fee means the doctor or clinician's charge. Facility fee means the hospital-owned location's charge. Same appointment, 2 bills. The billing category changed before the patient even knew there was a category. Now you might be thinking, okay, if I'm actually in a hospital, maybe that makes sense. Sometimes. But here's what most people don't realize. You can get hit with a hospital facility fee even when the visit feels nothing like a hospital visit. You might be in a clinic across town. You might be seeing the same specialist you've seen for years. You might be in the same office suite with the same receptionist and the same weird framed watercolor in the hallway. The only thing that changed is that the practice got acquired by a hospital system, and now the visit may be billed like hospital outpatient care. In other words, one of the most expensive parts of your appointment might not be the doctor. It might be the ownership structure. Most people think the expensive part of healthcare is the doctor. They assume, well, I saw a specialist, so that's why the bill is high. Or, I went to a big medical system, so I guess that's just what it costs. But in many cases, the doctor's work is only one part of the bill. The facility can bill you too. And sometimes the facility fee is bigger than the doctor's fee. Imagine ordering a $17 burger and getting a second bill for $42 because you ate it inside the restaurant. That sounds absurd. In healthcare, that basic idea is completely normal. And before anyone jumps into the comments and says, "Well, Nick, hospitals have overhead." Yes, of course they do. Hospitals need lights, nurses, cleaning staff, billing departments, compliance teams, equipment, emergency readiness, and all of that costs money. But the problem is not that hospitals have expenses. The problem is that consumers often have no idea when a routine appointment is going to be billed as a hospital outpatient visit. No idea what that means. No real opportunity to compare prices before they're already financially committed. That's the issue. The argument sounds reasonable until you realize it can apply to a regular office visit. That's where the argument gets slippery. Because the controversy is not whether hospitals have overhead. They do. The controversy is whether you should be charged hospital-level overhead when you did not receive hospital-level care. That is the entire game. Let's break down the basic math. A normal adult primary care visit in a physician office, about $116. Same type of visit in a hospital outpatient setting, about $217. That difference is about $101. Now imagine you have a high deductible health plan. Your deductible is $3,000. You have not hit it yet, so you are not thinking insurance will handle it. You are thinking, oh no, I am the insurance. Because until your deductible is met, a lot of these negotiated prices flow straight into your wallet like a financial fire hose. So the doctor visit you mentally budgeted as maybe $100 or $150 becomes $217. Now add a lab, add imaging, add a follow-up, add a specialist. And suddenly the real cost is not one dramatic medical disaster. It is the repeated little ambush. $101 here, $240 there, $423 after a follow-up, $700 after something that felt routine. Here is the part that should bother you. The most expensive part of the visit might not be the doctor, the test, or the medicine. It might be the billing status of the room you were sitting in. This is why medical bills create a very specific kind of anxiety. It's not just that they're expensive, it's that they arrive after the decision has already been made. At a restaurant, you see the menu before you order. At a mechanic, you usually get an estimate before they do the repair. With healthcare, you often get the price after your body has already had the audacity to need help. And that changes your psychology. Because when you are sick, scared, in pain, or dealing with your child's health, you are not comparison shopping like you're buying headphones. You are not standing outside the clinic saying, I wonder whether this facility uses provider-based billing. No, you're thinking, can someone please tell me if this rash is normal? And that is exactly why this fee is so powerful. It appears at the moment when the consumer has the least leverage. Most people think medical pricing is based on what happened to them. What test did I get? What treatment did I receive? How complex was my visit? How much time did the doctor spend? But in many cases, price is also based on where the system says you received care. Not where you think you received care. Where the billing code says you received care. And that distinction is massive. Here's what most people don't realize. The system does not need to change your experience to change your price. It only needs to change the billing category. Same place, different owner, new bill, that is not medicine, that is billing engineering. And billing engineering is what this channel exists to explain. Let's make it concrete. Say you have 3 visits in a year. Visit 1, primary care follow-up. Doctor office price, $116. Hospital outpatient price, $217. Difference, $101. Visit 2, your child's wellness visit. Physician office price, $144. Hospital outpatient price, $240. Difference, $96. Visit 3, simple imaging. Physician office price, $61. Hospital outpatient price, $227. Difference, $166. Total extra cost from site of care pricing, $363. That is not one catastrophic medical emergency. That is one family trying to be responsible. That $363 is not a luxury upgrade. It is not better medicine. It is the price of not knowing how the room was classified. And this is the psychological trap. The system tells you to get preventive care. Go to the doctor early. Don't wait until it gets worse. Get your checkups. Follow up. Do the responsible thing. Then you do the responsible thing, and the bill punishes you for not knowing the ownership structure of a clinic. Look, I'm pretty financially nerdy. I read this stuff for fun, which is probably something I should discuss with a professional. And even I think this is unreasonable, because the average person cannot realistically know which clinic is independent, which one is hospital-owned, which one bills as outpatient, which services trigger a facility fee, which insurance plans cover it, and whether the charge will hit the deductible. That's not consumer choice. That's a scavenger hunt with financial consequences. Now let's talk about the bigger trend behind this. Hospitals have been buying physician practices for years, and this matters enormously for your wallet. Because when a hospital acquires a medical practice, even if that practice stays in the exact same building, with the exact same doctors, with the exact same staff, it may now be designated as a hospital outpatient department, and the moment that happens, the billing can change. Not the medicine, not the waiting room, not the doctor's brain, the billing. According to AMA data, private practices accounted for 42.2% of physicians in 2024, down from 60.1% in 2012. Stop for a second and think about what that means. Before, a lot of people went to doctors who owned or worked inside independent practices. Now more and more doctors work inside large systems. And when the system owns the office, the system controls how the visit is billed. This is where it gets really interesting. A hospital system does not have to be evil to create a bad incentive. That's important. I don't want to make this cartoonishly simple. Individual doctors are often not the villain here. Many doctors do not set facility fees. Many doctors don't even know what the patient will be charged. They may be just as frustrated and confused by the billing system as their patients. The problem is incentive alignment. The hospital system is rationally optimizing for its financial model. The insurer is negotiating inside that system. The billing department is processing the claim. And you, the patient, are the one absorbing the cost of that optimization. Understanding that helps you fight it more effectively. You're not fighting a single bad guy twirling a mustache. You're navigating a system with misaligned incentives, and systems can be navigated. But first, you have to stop assuming that in-network means safe. This is one of the biggest myths in American healthcare. In-network does not mean affordable. It means the provider has a contract with your insurance company. That contracted rate can still be very high. And if you have a deductible, you may be responsible for the full negotiated amount until your deductible is met. The phrase in-network makes people relax. But in American healthcare, in-network does not mean safe. It just means the trap has a negotiated price. Let's do a simple example. You have a high deductible health plan with a $3,000 deductible. You go to an independent specialist office. The doctor bills $300. Your insurance negotiates it down to $180. You haven't met your deductible, so you owe $180. Annoying, but manageable. Now take the same exact visit at a hospital-owned outpatient department. The doctor bills $300. The hospital facility bills $700. Insurance negotiates the doctor portion to $180 and the facility portion to $420. Now your total allowed amount is $600. You haven't met your deductible, so you owe $600. Same kind of visit, same 15 minutes, same insurance. But the site of care changed the bill from $180 to $600. That is the entire game. And this is why I get a little frustrated when people say, just get insurance. Yes, you should usually have health insurance. Health insurance protects you from catastrophic risk. But insurance does not automatically make healthcare affordable. Insurance is not a coupon. Insurance is a contract. And if you don't understand how that contract interacts with where you receive care, you can get hit with charges that feel completely disconnected from the actual experience you had. Here's the mindset shift. Insurance is not the same thing as price protection. Most people do not behave like that's true. They behave like the insurance card is armor. It's not. It's a pricing framework with deductibles, co-insurance, negotiated rates, site of care rules, and administrative confusion stacked on top of each other. So when a facility fee shows up, people react in two stages. First, confusion. What even is this? Then, resignation. Well, I guess that's just healthcare. And that second reaction is where the system wins, because the second you stop questioning the structure, you stop looking for ways to lower the bill. A RAND analysis looking at 2022 claims found employer-sponsored plans paid hospitals, on average, about 254% of what Medicare would have paid for the same services. That does not mean your bill is always 254% of Medicare. It means the pricing power in this system is much bigger than most people assume. Now let me show you how this plays out in real life. Imagine you go to a specialist for a follow-up. The physician's professional fee is $220. Insurance knocks that down to a negotiated rate of $165. Fine. But because the visit happened in a hospital-owned outpatient setting, there's also a facility fee of $850. Insurance negotiates that down to $620. So your total allowed amount isn't $165, it's $785. If you haven't met your deductible, you could owe almost all of that. If you have met your deductible and you owe 20% coinsurance, you still owe roughly $157. And that's for a normal follow-up visit, not surgery, not an overnight stay. Not one of those dramatic TV scenes where 6 people run into the room yelling acronyms. A visit. The patient sees one room, one nurse, one doctor, one desk. The bill sees a hospital outpatient department. Guess which version wins? This is why the fee feels especially insulting. The patient compares the bill to the visible experience. You saw one room, one nurse, one doctor, one desk. You did not see the back-end overhead the hospital says you're paying for. Now, whether those charges are justified is a policy debate, but psychologically, patients think in concrete terms. I was there for 18 minutes. Why is this $620? That emotional mismatch is real. People don't mind paying for visible value. They hate paying for invisible overhead they never clearly agreed to. Let's talk about Megan. This is a composite story, but it's built from real patterns. Megan had been going to the same OBGYN office for years. Same location, same doctor, same check-in routine. Then the practice got absorbed into a regional hospital system. No giant warning, no blinking banner saying, "Hey, by the way, your cost structure may now be completely different." She goes in for a routine visit. Everything feels normal. A few weeks later, 2 claims show up. One is the professional bill, annoying but expected. The other is a hospital outpatient facility charge. And what's important here is not just that she was angry. At first, she wasn't angry. She felt stupid. She thought, did I miss something? Did they tell me? Am I just bad at insurance? That is a huge part of why bad financial systems survive. They make the consumer feel confused enough to blame themselves. And once people feel dumb, they get quiet. They stop pushing back. They assume the problem is their own lack of expertise instead of a billing structure that is hard to understand by design. Have you noticed how many expensive systems stay expensive by making you feel uninformed instead of making themselves clear? That is not an accident. If you remember nothing else from this video, remember this. Confusing billing is not proof that you're bad with money. A lot of this stuff is confusing because the system was not designed around patient understanding. Now, I want to challenge another assumption because this one costs people a lot. A lot of people think, if the care is connected to a hospital, paying more is just part of getting safer or better treatment. Sometimes that's true. If you have complications, serious risk, or you truly need hospital-level support, absolutely. But for many routine outpatient services, the higher price often reflects the site of care more than a dramatic difference in the care itself. That's the key. For a lot of people, the question isn't just, what service am I getting? It's, where is this service being billed? That's the hidden lever. 2 people can get basically the same category of care from equally qualified clinicians and owe wildly different amounts simply because one visit was classified as hospital outpatient. Let's do a couple more examples. A basic infusion at an independent center might have a negotiated price around $1,200. At a hospital outpatient department, maybe it's $2,100 or $2,600. If your coinsurance is 20%, that's the difference between owing $240 and owing $420 to $520. That's not a rounding error. That's groceries. That's a utility bill. That's part of your rent. Or take an MRI. At a freestanding imaging center, the negotiated rate might be $600 to $1,000. At a hospital outpatient department, it could be $1,800, $2,400, or more in some markets. With 20% coinsurance, the difference between owing $160 and owing $480 is huge. And yes, somebody is going to say, well, my insurance covered my MRI, cool. Sometimes it does. But millions of Americans are in high deductible plans. If you haven't hit your deductible, the site of care difference comes directly out of your pocket. And this is one reason medical bills feel uniquely stressful. If you overpay for a toaster, you know immediately. If you overpay for a medical visit, you usually find out weeks later. By then, the decision already happened. That lag matters. It disconnects the moment of choice from the moment of pain. So patients don't shop the way they would for flights or phones because there's no immediate feedback loop. You already had the test. Then the invoice shows up like a financial jump scare. This is where a small hidden fee becomes a full-year financial problem. It doesn't just change one appointment. It changes your deductible, your cash flow, and sometimes whether you keep getting care. Let me show you the exact mental trap. When a doctor says, go downstairs for imaging, your brain is not asking, is this the lowest cost site of care? Your brain is thinking, great, one less thing to manage. That feeling of convenience is real. It's also expensive, because the easiest option in healthcare is very often not the cheapest option. Here are the real psychological reasons people miss facility fees. Authority bias. If the doctor's office says go here, most people go there. They assume the medically recommended location is also financially reasonable. Those are not the same thing. Urgency. If you're in pain, stressed, pregnant, anxious, or trying to get answers, price shopping drops down the priority list. Of course it does. Language fog. Provider-based billing. Facility component. Hospital outpatient department. These are billing phrases, not normal person phrases. Learned helplessness. After enough confusing insurance experiences, people stop believing questions will help, so they pay first and verify later. And maybe the biggest one, premium blindness. If you know you're already paying a ton for insurance every month, you start to think of yourself as covered. So you scrutinize the point of care bill less aggressively than you would with almost any other purchase. That mental shortcut is expensive. Be honest. How many times have you assumed in-network meant reasonably priced? Because those are not the same sentence. Now you might be thinking, okay, even if this is true, what am I supposed to do? I'm not going to interrogate a receptionist every time I need a checkup. Fair. I'm not saying you need to become an insurance attorney to get blood work done. I am saying that a few specific questions can save you hundreds or thousands of dollars. And before I give them to you, I want to be clear about something important. Facility fees are not always errors. They are not always illegal, and they are not always avoidable. That matters because if you go into this thinking every charge disappears the second you complain, you're going to get discouraged fast. The goal is not magical thinking. The goal is to reduce avoidable surprises, identify bad assumptions early, and challenge charges when the facts are on your side. That is a much more profitable mindset. And the craziest part? One 7-word question can prevent a 4-figure bill. Here it is. Will this include a separate facility fee? That question alone can change everything. Then follow it with these. Is this visit being billed as hospital outpatient or provider-based? Is there a freestanding or independent location where I can get the same service? Can I get the CPT code and estimate in advance? Is this location on campus or off campus? Do you offer prompt pay discounts or financial assistance if my out-of-pocket is high? That's it. Not vague questions like, will this be covered? That question is too broad and the answer is often useless. You want specific billing language because vague questions produce vague answers. Let's say a guy named David needs a colonoscopy. What he thinks he needs to solve is simple. Find a good GI doctor who takes his insurance. What he actually needs to solve is location. One hospital-owned outpatient setting pushes his expected patient responsibility to around $1,100, depending on pathology and how the encounter gets billed. An in-network ambulatory surgery center puts the estimate closer to $400 to $600. That's a several $100 difference for a procedure that most people do not think of as shoppable. And that's the pattern. The biggest savings are often hiding in categories people assume are non-negotiable. If you can save $500 by driving 15 more minutes, is that inconvenient? Or is that one of the highest paid errands you'll run all year? Here's what most people don't realize. Hospital consolidation changes billing faster than patient behavior changes. Patients still feel like they're visiting their doctor. Financially, they may now be visiting a hospital outpatient department. That is a different pricing universe. And because the emotional relationship is still with the doctor, patients don't notice the ownership shift until the bill teaches them. This is where it gets really interesting. A facility fee does not just increase one bill. It can change your entire year. Let's say your deductible is $3,000. A facility fee-heavy visit in February eats up $900. Then imaging in March adds another $1,200. Now you've burned through over 2/3 of your deductible before spring. That changes your cash flow, your emergency fund, your stress level, and sometimes your willingness to keep getting care. So a facility fee is not just a line item. It can reshape your entire financial year. And this is where the medical debt numbers matter. KFF's healthcare debt survey estimated that about 100 million people in America, including 41% of adults, had some form of healthcare debt. Not all of that comes from facility fees, obviously. But opaque medical billing is absolutely part of the story. When roughly 41% of adults are carrying healthcare debt, we are not talking about a niche billing annoyance. We are talking about a major household finance problem. Now you might be thinking, if the doctor tells me to use the hospital system's location, I probably don't have a choice. Sometimes that's true, but not always. A better question is, do I need this location for medical reasons or is this just the default workflow? Those are different. If you need hospital-level support, use it. If it's routine and there's a lower-cost, clinically appropriate option, at least ask. Another objection. I'm too busy to call around. I get it. Nobody wants to spend lunch break talking to insurance. But compare 20 minutes on the phone with $800 in avoidable charges. That's a pretty good hourly rate. Another one. If it's in-network, it shouldn't matter that much. Wrong. In-network means there's a contract. It does not mean the price is low. And maybe the biggest objection of all, this stuff is too confusing. I'll just pay whatever they send me. That mindset is exactly why the system keeps getting away with it. You do not need to master every billing rule. You just need to become slightly harder to overcharge. You do not need to be an expert to save money here. You just need to ask one level deeper than the average patient. Here are some warning signs a facility fee might be involved. The clinic uses the hospital system's branding. Your estimate mentions hospital outpatient, provider-based, or facility. You're getting care at a practice that used to be independent. You receive separate bills for the same encounter. The estimate splits the professional component and facility component, or the same service somehow costs much more at one location than another. None of those automatically mean the bill is wrong. They just mean you should slow down and ask questions before the appointment if you can. And let's talk about the emotional side for a second. When people get a medical bill they don't understand, they usually do one of three things. They ignore it, they panic and pay it, or they jump straight into a payment plan. All three are understandable. None is ideal. Ignoring it reduces options. Panic paying locks in a charge you might have reduced or appealed. And automatic payment plans can create a false sense of responsibility. You feel like you're handling it, but you may just be handling a bad bill in the most convenient possible way for the biller. So here's the rule. Before you pay a dime, buy yourself clarity. The first win is not lowering the bill. The first win is understanding the bill. Because once you understand it, you can decide whether to challenge it, negotiate it, or pay it. Until then, you're just reacting. That means get the itemized bill. Compare it with the explanation of benefits from your insurer. Confirm the date, codes, and location. Ask whether a separate facility fee was applied. Ask whether the coding and site classification were correct. Ask whether there are prompt pay discounts, financial assistance options, or reprocessing opportunities. Then decide how to pay. Clarity first, payment second. That order matters. Would you ever send $900 to someone before checking what the charge was for? Of course not, but people do the medical bill version of that every day. Let's run a more detailed example. Say you're on a high deductible health plan with a $4,000 deductible and 20% coinsurance after that. You need 3 outpatient services this year: a specialist consult, an MRI, a minor outpatient procedure. At independent settings, maybe your allowed amounts are specialist, $180, MRI, $750, procedure, $1,600, total, $2,530. Painful, but still below your deductible. Now same basic care pattern in hospital outpatient settings. Specialist, $780, MRI, $2,100, procedure, $3,200, total, $6,080. See what changed? You did not suddenly consume more care. You crossed your deductible faster because the site of care pricing was higher. So now you pay the first $4,000, then 20% of the remaining $2,080, which is another $416. Total out of pocket, roughly $4,416, versus $2,530 in the independent setting version. That's nearly a $1,900 difference. For a lot of families, $1,900 is not a detail. That's a real financial event. Same health problem, same year, same insurance plan. Nearly $1,900 gone because of where the care was billed. That's the kind of number people remember. And this is why I keep saying facility fees are both a math problem and a psychology problem. The math problem is obvious: bigger bills. The psychology problem is more dangerous. People don't realize they're making a site of care decision, so they never consciously weigh the trade-off. It's like being offered 2 flights without being told one costs $700 more until after you land. No one would tolerate that in normal life. But in healthcare, people tolerate versions of it constantly because the system has trained them to. A charge can be legal, in-network, processed correctly, and still be financially terrible. Those are 4 different questions. Quick side note, because this comes up a lot. Some people hear surprise bill and think, doesn't the No Surprises Act handle this? It helps in certain situations, especially around out-of-network emergency care and some non-emergency services at in-network facilities. That matters. But it does not erase all high in-network cost sharing. And it does not make every facility fee disappear just because it felt surprising to you. That distinction is important. A charge can feel outrageous and still be fully allowed under your plan, which is exactly why prevention matters more than outrage after the fact. So if I were making a simple rule for this, it would be, before any non-emergency outpatient service that could cost real money, ask, what exactly is the service? Where exactly is it being billed? What is my estimated responsibility? Is there a lower-cost, clinically appropriate site of care? That little 4-question filter will solve more problems than most people think. And if you want the even simpler version, here it is. Whenever a hospital system is involved, assume nothing about the final price until you confirm the billing structure. That mindset alone will save a lot of people. The next time a scheduler says, "We have an opening at our hospital location," are you going to hear convenience or are you going to hear potential cost? That awareness is the upgrade. Now I want to give hospitals the strongest version of their argument, because understanding the argument actually makes the problem clearer. Hospitals will say facility fees help cover the cost of maintaining outpatient departments, staffing, technology, regulatory requirements, charity care, emergency readiness, and the reality that hospitals treat patients regardless of ability to pay in emergency situations. And some of that is true. Hospitals are expensive to run. They face real costs that a small independent clinic may not face. Also, hospitals argue that they need facility fees to support services that lose money but are essential to the community. So this is not as simple as hospitals bad. But here's the tension. Even if the fee is justified on a spreadsheet, that does not mean it is okay to surprise the patient with it after the fact. Consumers still have a right to transparency, because here's my issue. If a hospital believes a facility fee is justified, then disclose it clearly before the appointment. Tell people, put it in plain English, not buried on page 11 of an intake form, not hidden behind your insurance benefits may vary, not revealed after the patient has already received care. Say, this location is billed as a hospital outpatient department. You may receive 2 bills, one from the clinician and one from the facility. Your out-of-pocket cost may be higher than at an independent office. That would allow people to make informed choices. And if hospitals are nervous that people would choose lower cost settings after seeing that disclosure, well, that tells you something. Because when a business model depends on customers not understanding the price until later, that is not a consumer-friendly business model. Now here's another surprising piece. Your doctor may have no idea what you're going to be charged. This is one of the weirdest parts of healthcare. In most industries, the person selling the service has at least some connection to the price. Not always, but usually. In healthcare, the doctor may know the medicine and know the clinical reasoning, but have almost no visibility into your insurance contract, deductible status, facility fee, CPT codes, or negotiated rate. So when you ask, how much will this cost, the doctor may genuinely not know. That doesn't mean they're lying. It means the billing system is separated from the clinical system. The person recommending the service may not know whether the next room costs you $80 or $800, and that creates a dangerous gap. Because the doctor is thinking medically. The patient is thinking financially. The billing department is thinking administratively. The insurance company is thinking contractually. And nobody is really responsible for giving the patient one clear number. So you have to become the connector. Is that fair? No. Is it necessary? Unfortunately, yes. This is one of those moments where I wish I could tell you, don't worry, the system will protect you. But in many cases, the system will not protect you unless you ask very specific questions. So let's turn this into a 3-call survival script, not a 40-step homework assignment. 3 calls: the provider, the billing department, the insurance company. Before a non-emergency visit, test, procedure, or specialist appointment, ask these questions. First, is this location billed as a hospital outpatient department or as a regular physician office? Second, will there be a separate facility fee? Third, what billing codes do you expect to use? Now, for a basic office visit, they may not know the exact code because it depends on complexity. But for imaging, labs, and scheduled procedures, they may be able to give you CPT codes. Fourth, can you provide a cost estimate? Fifth, are there lower-cost in-network sites where I can receive this same service? This is especially important for labs, imaging, physical therapy, sleep studies, infusions, and outpatient procedures. Sixth, can this be done at an independent office, freestanding imaging center, ambulatory surgery center, or non-hospital lab? Here's the uncomfortable truth. The referral your doctor gives you is often optimized for medical workflow, not your wallet. Now you might be thinking, Nick, I do not have time to become a medical billing investigator every time I need care. And I agree, you should not have to. But you also don't need to do this for every tiny interaction. Focus on the expensive categories. Specialist visits at hospital-owned clinics, imaging, procedures, infusions, emergency room visits that might be urgent care appropriate, labs ordered through hospital systems, anything where the site of care could change the bill dramatically. You're not trying to optimize every $12 charge. You're trying to avoid the $1,200 surprise. Now let's talk about emergency rooms, because this is where facility fees can get really intense. When you go to the ER, you are usually billed for the clinician and the facility. The facility fee is often tied to the level of service. A level 1 or level 2 ER visit might be lower acuity. A level 4 or level 5 visit can be much more expensive. And here's where patients get upset. They say, I waited for 3 hours, saw someone for 6 minutes, got Tylenol, and now the hospital says this was a high-level ER visit. The hospital may say the level is based on resources used, risk, assessment, documentation, and complexity. The patient says, I barely received anything. Both things can be true in a weird way. But financially, the patient gets the bill. A 6-minute interaction can produce a 4-figure bill because you were not just paying for those 6 minutes. You were paying for access to the emergency machine. So what should you do? First, do not avoid the ER for true emergencies. Chest pain, stroke symptoms, severe trouble breathing, major trauma, severe allergic reactions, suicidal crisis, uncontrolled bleeding. Go to the ER. Do not turn a medical emergency into a personal finance optimization exercise. That is not what I'm saying. But for non-emergency situations, urgent care or same-day primary care can be dramatically cheaper. A sore throat at urgent care might be $150. A sore throat at the ER might generate a bill of $1,000 or more, depending on your plan and the facility fee. And psychologically, this is hard because when you're scared, you want the highest level of care available. That makes sense. But after the panic passes, the bill remains. So the best time to decide where to go is before you're sick. Make a simple care map. Know your nearest in-network urgent care. Know your primary care after-hours line. Know whether your insurer has a nurse line. Know which hospital is in-network for true emergencies. When you are calm, build the plan. When you are panicking, follow the plan. Now let's say the bill already arrived. What do you do now? Step 1. Do not immediately pay the first bill just because it looks official. I'm not saying ignore it, I'm saying review it. There's a difference. Medical bills are often confusing, and errors happen. Ask for an itemized bill. You want to see what codes were billed, what the facility charge was for, what insurance allowed, what insurance paid, and what you owe. Step 2. Compare the bill to your explanation of benefits or EOB. The EOB comes from your insurance company. It is not a bill. It shows the billed amount, the allowed amount, what insurance paid, adjustments, and your responsibility. Make sure the provider bill matches the EOB. If your EOB says you owe $280 and the provider bill says you owe $480, call and ask why. Never pay a medical bill just because the paper looks official. The official-looking number can still be wrong. Step 3. Ask directly about the facility fee. Say, I was not aware this visit would include a facility fee. Can you explain why this was charged and whether it can be reviewed or reduced? Step 4. Ask for a coding review. You can say, I would like this claim reviewed for coding accuracy, including whether the facility level was appropriate for the services actually provided. This is especially relevant for ER bills and outpatient visits where the charge seems disproportionate. Step 5. Ask about financial assistance. This is huge. Nonprofit hospitals generally have financial assistance policies, and many people assume they won't qualify because they're not extremely low income. But some hospital assistance policies extend to middle-income households, especially for large bills. You might qualify for a discount, a partial write-off, or an interest-free payment plan. Do not assume. Ask. Step 6. Negotiate. You can ask, if I pay in full today, is there a prompt pay discount? Or is there a self-pay rate that would be lower than my insured responsibility? Now, sometimes they'll say no. Sometimes insurance contracts limit what they can adjust, but sometimes they'll reduce the balance. And a 5-minute phone call that saves $300 is a pretty good hourly rate. Now you might be thinking, isn't this exactly why I pay insurance premiums? Why am I doing all this work? Yes. Emotionally, I agree with you. If you pay $500, $800, $1,200 a month in premiums, it feels insane that you also have to become a part-time billing auditor. But insurance has changed. A lot of people now have high deductibles, co-insurance, narrow networks, and complicated benefit designs. That means the sticker price and the negotiated rate matter a lot more to you than they used to. If you had a $20 copay for everything, maybe you wouldn't care as much. But if you have a $3,000 or $6,000 deductible, you are exposed to the negotiated price. And once you understand that, your behavior has to change. You cannot shop for care like every in-network location is financially identical. They are not. In-network is not one price. It is a category with wildly different prices hiding inside it. This is the psychological shift. Old mindset. I have insurance, so I'm covered. New mindset. I have insurance, but I still need to understand network, site of care, deductible, co-insurance, and billing structure. That is less comforting. But it is more accurate. And accuracy saves money. Think of healthcare like buying an airline ticket, except worse. You search for a flight. One airline says the ticket is $300. Another says $450. But then you realize one charges for bags, one charges for seat selection, one has a change fee, one lands at a different airport, and one has a 6-hour layover. The base ticket price is only part of the cost. Healthcare is similar, except the prices are hidden, the terms are confusing, and the bill arrives after the flight. A facility fee is like the airline saying, yes, the pilot fee was $180, but because you boarded the plane at our premium terminal, there is an additional terminal usage fee of $520. And you say, was there another terminal? And they say, maybe. And you say, why didn't anyone tell me? And they say, it was your responsibility to understand your benefits. That's why this feels absurd. But again, absurd does not mean unavoidable. The goal is not to make the system fair today. The goal is to stop being the easiest person in the system to overcharge. Let me give you one more story. Mark has a minor outpatient procedure at a hospital. Everything goes fine. A month later, he has a follow-up visit. He assumes the follow-up is included, or at least cheap. He drives to the same hospital campus, goes to a clinic, talks to the specialist for 10 minutes, and leaves. Then the bills arrive. Professional fee, $160. Facility fee, $740. Total patient responsibility, $900 because he hasn't met his deductible. Mark is furious. He calls and says, I was there for 10 minutes. Billing says, this was billed correctly as a hospital outpatient visit. He says, but I didn't use the hospital. They say, the clinic is part of the hospital. He says, no one told me that would cost $900. And this is the key sentence. They say, your insurance determines your responsibility. That phrase sounds helpful, but it often shuts down the conversation. Do not let it. That sentence is partly true, but incomplete. Yes, insurance determines the patient responsibility from the claim. But the hospital determined the billing structure. The patient was never clearly told there would be a facility charge. So what should Mark do? He should ask for an itemized bill. Compare the EOB. Ask whether the follow-up could have been billed differently. Ask for a coding review. Ask for financial assistance. Ask for a discount. Ask whether future follow-ups can be done at a physician office location or via telehealth without a facility fee. And going forward, he should ask before every appointment, will this visit have a facility fee? Because Mark's mistake was not that he got care. His mistake was assuming the follow-up appointment was financially ordinary. And that is a mistake many reasonable people would make. Now here's another wrinkle. Sometimes telehealth visits connected to hospital outpatient departments can also involve facility-type billing. That surprises people even more because they're sitting at home. They're like, what facility did I use? My kitchen? Again, whether this happens depends on the provider, payer rules, location, and billing structure. But the lesson is the same. Before telehealth through a hospital system, ask, will this be billed as a standard telehealth professional visit? Or will there be any hospital outpatient or facility charge? Because the intuitive assumption is virtual visit equals cheaper. Often, yes. Always, no. A video visit can feel like the cheapest possible version of care, but the billing system does not always care how it feels. And that's the theme here. Do not rely on intuition in medical billing. Your intuition was built for normal markets. Healthcare is not a normal market. So let's make this extremely practical. I don't want you leaving this video thinking, wow, healthcare is broken, and then doing nothing. I want you leaving with a script. Here is your facility fee action plan. Number 1, identify hospital-owned locations. Before scheduling, look at the practice website. Does it say Department of a Hospital? Does the address appear on a hospital campus? Does the paperwork mention Hospital Outpatient Department? Does the portal belong to a large health system? Those are not automatic red flags, but they are clues. Number 2, ask the facility fee question. Use this exact wording. Will this appointment generate a separate facility fee or hospital outpatient charge? Number 3, ask your insurer for site of care comparisons. Some insurers have cost estimator tools. They are not perfect, but they can reveal huge differences. Search for imaging, labs, endoscopy, physical therapy, and outpatient surgery. Number 4, redirect routine services when clinically appropriate. For labs, ask whether you can use an in-network independent lab. For imaging, ask whether a freestanding imaging center is acceptable. For procedures, ask whether an ambulatory surgery center is appropriate. For therapy, compare hospital-based physical therapy versus independent PT clinics. One phone call before the appointment can be worth more than a month of cutting small expenses. Number 5, document everything. Write down the date, time, person you spoke with, and what they said. This matters if you later dispute a bill. You do not need a fancy system. A note in your phone is enough. Number 6, never assume referrals are cost optimized. Doctors often refer within their own system because it's convenient, integrated, or standard workflow. That does not mean it is the cheapest option. Ask, is there any medical reason I need to have this done at the hospital, or can I use a lower-cost in-network site? That phrase is powerful because it respects the medical judgment while raising the financial issue. Let's also talk about what not to do. Do not skip necessary care because you're afraid of facility fees. That can make everything worse. A small medical problem can become a large medical problem, and a manageable bill can become a catastrophic bill. Do not assume every hospital-owned clinic is ripping you off. Sometimes the hospital location is clinically appropriate. Sometimes your insurance design makes the difference smaller. Sometimes you have already met your out-of-pocket max, so the marginal cost to you is zero. Do not be rude to billing staff. I know you're angry. I know the bill feels ridiculous, but the person on the phone probably did not design the system. Be firm, be persistent, be specific, but don't be abusive. Do not put medical bills on a credit card without thinking. Once you convert a medical bill into credit card debt, you may lose access to hospital financial assistance or zero-interest payment plans, and now you're paying credit card interest. Ask for a payment plan first. A medical bill on a payment plan may be annoying. A medical bill turned into credit card debt can become a financial fire, and do not assume the first no is final. Sometimes you need to call again. Sometimes you need a supervisor. Sometimes you need to submit a written appeal. Persistence matters. The bigger lesson is that healthcare costs are not just about being sick. They're about systems, ownership systems, billing systems, insurance systems, coding systems. And the average person is thrown into all of this while they are stressed, sick, busy, or scared. That is why I want you to develop a different kind of financial reflex. When someone says, go here, you ask, how is here billed? When someone says, this is in network, you ask, what is my estimated allowed amount? When someone says, this is part of the hospital, you ask, will there be a facility fee? When someone says, your insurance determines that, you ask, can you show me the itemized charges and coding? This is not about being cynical, it's about being awake. Because once you see how site-of-care billing works, you cannot unsee it. You realize that two people can receive nearly identical care and pay completely different amounts because one walked through a hospital-owned door and the other walked through an independent clinic door. That is not intuitive, but it is real. The person who asks one awkward question before care may pay less than the person who politely follows every instruction without asking anything. Look, I know this is annoying. I know it feels ridiculous that you have to think this way while also managing symptoms, work, family, insurance, and everything else. And I know some people hear this advice and think, great, now I have to be my own billing advocate too? Kind of, yes. Not because that's fair, because it's profitable. This is the part of personal finance people underestimate. A lot of financial success is not doing flashy, sophisticated things. It's catching boring, expensive things before they snowball. Facility fees are boring. They are also expensive. And because they sound technical, people underestimate them. I remember hearing from someone who went in for what she thought was a basic follow-up after a minor procedure. She budgeted a couple $100s because she knew she still had deductible left. The bill came in closer to $1,300 than $300. Not because the doctor spent 4 times longer with her, not because there was some complication, because the setting triggered a facility charge she never really understood up front. And what stuck with me wasn't just the number. It was what she said afterward. She said, I feel like I can never financially relax around healthcare, even when I'm trying to do the responsible thing. That line explains a lot. When the rules feel hidden, people stop trusting the game. And when people stop trusting the game, they either disengage or over-comply. Neither is good for your finances. The goal here is not to become paranoid. It's to become expensive to fool. So let's end with exactly what to do if you get one of these bills. Don't pay immediately just because the due date scared you. Check the explanation of benefits first. Request the itemized bill. Ask specifically whether the charge includes a facility fee or provider-based billing. If the bill seems inconsistent with what you were told, say that clearly and ask for review. If the site classification or coding seems wrong, escalate to the billing office and then the insurer. If the bill is valid but unaffordable, negotiate before defaulting to a long payment plan. Those are not miracle tactics. They are just the highest probability moves. Here's what most people don't realize. Hospital facility fees are not random bad luck. They're a predictable result of a system where ownership, billing classification, and pricing power matter a lot, and patients are often the last to know. Once you understand that, you stop personalizing every bad bill. You stop thinking, I must have messed this up. And you start asking, where was the pricing decision hidden? That is a much better question. Because when you ask better questions, you make better money decisions even inside messy systems. And that is what this channel is about. Not pretending every financial problem is easy, Not pretending you can spreadsheet your way out of every broken system, but learning where the leverage points are so you can stop losing money in preventable ways. So if you take one action after this video, let it be this. The next time you schedule a non-emergency outpatient appointment, ask whether the visit includes a separate facility fee and whether there is a lower-cost independent or freestanding option. That one question could save you hundreds of dollars, potentially thousands. And even if the answer is no, you'll walk in informed instead of blindsided. That alone lowers stress, and informed people make better financial decisions. Look, I get frustrated by this because I know how many people are trying hard, carrying insurance, following instructions, doing what they think is responsible, and still getting hit with bills they never saw coming. But I'm also optimistic, because once you can name the trap, it gets a lot harder for the trap to work on you. So don't just be insured. Be aware of site of care. Be aware of billing structure. Be aware of the words facility fee. That awareness is money, because the worst time to learn about a facility fee is after the bill arrives. The best time is before the appointment exists. And if the bill already showed up, don't panic, pay it. Review it. Compare it, question it, ask for help, because your money matters, your health matters, and you should not have to choose between protecting one and protecting the other. So before you click away, do one thing. Open your calendar, look at your next medical appointment, and write next to it. Ask about facility fee. That one reminder could save you hundreds of dollars. If this video helped you understand a bill you've received, hit the like button so more people see it. Subscribe for more videos on the healthcare and money decisions that can quietly wreck your budget. And in the comments, let me know. Have you ever been charged a facility fee for something that did not feel like a hospital visit? What was the appointment? What was the charge? And what do you wish you had asked beforehand? I read those, and your story might help somebody else avoid the same bill. Because these systems survive when nobody can name them. So name it. Facility fee, hospital outpatient billing, provider-based charge, the building bill. Whatever you call it, just don't ignore it, because they didn't break the law. They wrote it, and then they mailed you the invoice. Thanks for watching. I'll see you in the next one.